Thank you, sir. Good afternoon to all. We have been having a lot of COVID-related sessions, and the today's final session for today is about management of COVID suspected and confirmed pregnant women. So, since the pandemic is raging very high, women will be getting infected, and on top of that, if the pregnant women get infected with COVID-19 infection, there's going to be some different consideration. So, obs and gynae units of all hospitals have to be ready with some basic things. So, appropriate isolation of the pregnant women who are confirmed COVID-19 infection should be there. We should have facility to isolate these women. Basic refresher training of the all healthcare personnel dealing with the patient care should be given, and especially to use how to use the PPE kits, and especially with the video presentation. Sufficient PPE kits must be provided to all at all points of care, from emergencies to labor rooms to wards and the isolation wards, and the processes to take care of newborn babies also should be in place. So, what is COVID-19 infection in pregnancy? How does the transmission occur? The transmission is same as general population. Pregnant women do not appear to be at increased risk of infection. The risk level is almost same as the general population. But the reported cases of COVID-19 pneumonia till date, that we have 2 years data, are milder and with good recovery. That's a good news. But there is a risk of serious illness in women with comorbidities, especially if the woman has heart disease, diabetes, preeclampsia, or asthma. This risk gets multiplied, and they can have terminal or critically ill patients with COVID-19 also. Vertical transmission of the fetus is possible, but the data suggests that it is rare, so that worry is not there. At present, there are no recorded cases of vaginal secretions being tested positive for COVID-19, so vaginal delivery can be safely taking place, and there is no virus detected in the breast milk, which makes it safer to breastfeed these women, breastfeed the babies of these women. Effect on the pregnancy, because since we know the infection spreads by the droplet, stricter precautions are needed. Sometimes lockdown, isolation, which is needed to break the transmission chains, can cause anxiety and depression in pregnant women, and especially pregnancy is a phase when the women are already in a mood fluctuation mode, so they need more mental health support during these periods. Adverse perinatal outcome are observed only in a critically and severely ill patients, and they might have a slightly higher risk of premature labor and stillbirths. The perinatal outcomes in the women with a mild or moderate disease are similar to those observed in asymptomatic patients, and majority of the infants who are rooming in with their mothers with COVID positive mothers were shown to have negative PCR. So the breastfeeding does not transmit the virus to the babies. Effect on the fetus: there is no increased risk of miscarriage in early pregnancy. So there is no evidence of that the virus is teratogenic, but of course we don't have the long-term data, because we've been in the pandemic for just 2 years. COVID-19 infection is currently not an indication for medical termination of pregnancy, and asymptomatic COVID positive women have no ill effects on the pregnancy. Clinical presentation of these women is same as the general population, and as you know the incubation period for the COVID-19 infection is 5 to 7 days, and these women tend to be infected 2 days prior and 3 days after the appearance of symptoms. Symptoms are generally same for the other people, like fever, sore throat, dry cough, diarrhea very rarely, loss of smell and taste. Lab testing should be done as like any other general patient that you will do. Management of COVID infection in pregnancy: there are such general guidelines. These are the ICMR guidelines. So we have to follow the local testing guidelines. If the patient has symptomatic, she should be tested. If she is coming from foreign travel, she should be tested. If she has been in a contact with the person who is infected, or she was in isolation with the person at home who was in quarantine for COVID positive, she should be tested. Notify all COVID positive patients to the Infection Control Authority of your city. You have to maintain a registry of all COVID patients. Appropriate space management is very necessary to prevent transmission, because you're going to need separate delivery rooms and separate wards and isolation rooms for the COVID positive women. Advise wearing mask, social distancing, and hand hygiene for all pregnant women, irrespective of the positivity or negativity. Intrapartum facility should be provided at a tertiary with a minimum staff, because we don't want too many patients getting infected. So, if the COVID wards are there, isolation ward, we have to restrict the visitors to COVID wards, of course. And if the visitors do come in, we have to make them wear PPE kits, including gown, gloves, face masks, and eye protection. And face mask should not be removed until the woman is isolated comfortably in a suitable room. And the staff taking care of the COVID positive woman also should wear this PPE kits. There are some specific obstetric management consideration. So all patients should have a detailed travel history, exposure to the COVID-19 symptoms, and coming from hotspot area or compromised area. And you have to make sure that you have all this data before you can do the treatment. So there are certain do's and don'ts in pregnancy in a COVID infected patient. If the patient is at risk of COVID-19, she should be tested. So these include the patients who are coming from hotspot areas, containment areas, patients who have been abroad, or patients who have been in contact with the patients infected with COVID-19 or were in isolation with a patient at home who was positive. And as till the results come, you have to treat these women as positive, but do not delay any obstetric management till the test come. You have to reduce the investigations to the minimum. Do not do unnecessary investigations or ultrasonographies. Elective procedures, induction of labors which are not strictly necessary can be deferred, and if ultrasound is used for some reason, machines and equipment should be decontaminated immediately. And management regarding treatment of COVID-19 patients should be as similar to the non-pregnant patients, and effective treatment of COVID-19 with drugs, oxygen therapy and ventilation should not be withheld just because she is pregnant and with the care for baby. Vaccines are advocated in pregnancy, and all pregnant women and lactating women can be given vaccines. So during antenatal visits, you have to have minimum contact of the patient to the hospital, because every time the patient comes to the hospital, she is exposed to the hospital environs and the contaminated virus might be there. So reduce visits to 12, 20, 28 and 36 weeks unless the patient has a high risk factor. Symptomatic patients who are COVID positive can defer appointment for 7 days. We have to call them on phone and advise them to just keep a fetal kick count. When they come to the hospital for checkups or testing, they should take their own vehicle or call 108 and tell the ambulance driver about their condition. A woman who is positive should be quarantined for 14 days. Any woman who has not turned up for routine visit should be called after 3 weeks of care. And patient who has COVID negative but has symptoms should be also considered as suspected COVID patient. So intrapartum care, if this patient go into labor, you have to assess the severity of the symptoms in all these patients, because all women who are COVID positive may not have similar level of spectrum of symptoms. Some might have asymptomatic, some have mild symptoms, some moderate or severe symptoms. So you have to try these patients where they can be taken care of. Usually COVID treatment infection patient needs a multidisciplinary approach with the help of pulmonary medicine, infectious disease, pediatric specialists and obstetric care. Even ICU care will be needed for the critical care. Timing of the delivery is not decided by the COVID, it is at the discretion of the obstetricians. COVID per se does not mean that the termination of the pregnancy should be done. Delivery should preferably done at the tertiary care center, where all the facilities for ICU and pulmonary care, ICU care will be there. Electronic fetal monitoring should be used, and hourly oxygen monitoring should be done during labor. So if the patient is in labor, you have to monitor oxygen saturation, which should be always at all time 94% and above, and continuous fetal electronic monitor should be done. Mode of delivery has no impact on the COVID outcome. So it could be vaginal, it could be cesarean section. It is dependent on any maternal worsening condition or obstetric indication. COVID per se is not an indication for cesarean section, but when cesarean is needed, staff should be wearing the PPE kit. Instrumental delivery, when to use an instrument, is an individualized choice by the obstetricians, and do not use undue instrumental deliveries. But sometimes patient becomes hypoxic in labor and she is unable to push. In that condition, you can cut stage the second stage by use of forceps or vacuum. In COVID-19 critical care, you have to have hourly absolute observations of oxygen saturation, hourly respiratory rate should be monitored. Sometimes young and fit women can hold, even they become hypoxic, they can hold the respiration for long time and then suddenly become decompensated. So any rise of respiration rate indicates worsening condition. So in these conditions, in these women who are critically ill or severely ill with COVID infections and pneumonitis, radiographic investigation should be done. X-ray is not contraindicated. Even a CT chest with the shielding of the abdomen can be done in these women. It is not contraindicated. Do not withhold CT scans or X-ray chest just because the baby is for the fetal concerns. If the patient becomes febrile and she has all the symptoms of sepsis, so pyrexia is not alone because of the COVID, it could be because of bacterial sepsis. So sepsis should be done and antibiotics should be started. IV fluid should be given to resuscitate dehydration or in fluid depletion, but do not overload the lungs because there is a danger of pulmonary overloading. So try bolus infusions of the fluid around 250 to 500 ml at a time. Individualized FSR monitoring, do not do continuous. And indications for ICU, sometimes during the labor or immediately postpartum these patients become suddenly worse. So how do we know that? Suddenly the oxygen saturation drops below 93% at rest, the respiratory rate becomes more than 30, the PaO to the FaO2 ratio becomes more than 300 milligrams per Hg. There is a 50% lesion deterioration progression on CT scans within 20 to 48 hours, and this a quick SOFA score can be used to determine where the patient needs an ICU care. That quick SOFA count takes into account mental status, tachypnea and hypotension. And so this is about the ICU care. Postnatally, when the patient delivers, patient can be temporarily separated from the baby if the patient is confirmed COVID patient or she is a person under investigation. A separate isolation room should be provided for the infant and the baby. When the rooming in is practiced and the baby is lying with the mother and she wants to breastfeed, she can breastfeed, is not contraindicated, but she should take appropriate precautions and put on a face mask, and the face mask should be continuously covering the face till the time the breastfeeding is continued. Severely ill patients sometimes may need to be separated from the baby in the ICU care. During this temporary isolation, expression of the breast milk is advocated, and express breast milk before and after she should have hygienic practice, disinfect, and this express breast milk should be given to the baby by a healthy caregiver. Discharge, like the discharge of the hospitalized COVID-19 patient, general guidelines should be followed. Recovery should be considered when the test comes negative and the fetal and the neonatal conditions are appropriately handled. There are certain guidelines about COVID surgery in COVID patients. Elective procedures should be scheduled at the end of the operating list and with the full protective gears. Non-elective surgery should be carried out at the COVID positive, they should be carried out in a different theatre. Minimum staff should be present in the OT. Everybody in the PPE. Hand hygiene with 90% alcohol. If you have soiling of hands with blood or other products, so you should have the facility for washing hands by soap for 20 seconds and then use sanitizer if it is required. So to put it in a nutshell, screening and testing like a general population of COVID-19 infection, there is at present no known vertical transmission to the baby, so the fetus is not at exaggerated risk. Reduce the frequency of the visit to the hospital, reduce investigations so that the women have to come less and less to the hospital. Vaccines are safe, they can be given to the pregnant women. Side effects of the vaccinations are just injection site pain and sometimes transient fever, which is same as general population. Protective gear measures should be given. Cesarean section should be reserved only for sick patients. Separation of the baby is a doubtful area. They can be separated, they can be roomed in with the baby. Breastfeeding can be advocated with the adequate care. Isolation should be done after delivery. Instructions at the discharge should be given. Precautions to be taken by the patient, the home isolation till they become negative. So thank you. That was all about this. I bring it to Dr. Ohri for the second topic. The second topic.
Yes, so it was, I think, very elaborate and clarity on that issue that what we were talking about. And now we'll be talking about the abortion. Ma'am, Dr. Manjali ma'am will be taking up abortion, family planning services during this pandemic session, that is COVID-19. And this will be the session again taken by ma'am. Yeah, the last session. Yeah.
Thank you. This is just a word about abortion and family planning services in COVID-19 pandemic. This is a family planning division, Ministry of Health and family welfare guidelines. So we'll be talking about that. So National Family Planning Program basically focuses on the provision of quality short-term and long-term contraception, permanent sterilization for both men and women, counseling and services regarding family planning services, and safe abortions. And the current pandemic, however, has both affected this supply and demand of family planning services because of multitudes of reasons. So there are certain challenges of providing family planning services in the pandemic area. So we have seen there are low resources of the healthcare providers because of the COVID-19, because the second wave was really horrific. There were a lot of people positive and with a lot of morbidity and mortality. So a lot of able-bodied physicians were relocated, redeployment to the provision of COVID related services. So there were resources for providing family planning services was less. Second, there was a low prioritization of the family planning services, especially in the pandemic. Women did not give priority to the family planning services. Use of COPD, OCPs can be postponed according to them, because during the lockdown and during the home isolations, people were not advised to go to the hospitals to ask for these conditions. There were changes in the health seeking behavior of the community also because of fear of infection. They were not allowed by the family members or the society, if the healthcare givers also advising to stay at home, not to venture out unnecessarily. So this came in that category of unnecessary practices of seeking family planning advices. So people did not seek out these practices during the pandemic area. There was limited access due to mobility restrictions. During the lockdown, there were a lot of restrictions. The supply in the pharmacies were less, and the mobility of the people and the supply of the contraceptive services also was less. And there was some economic impact due to the loss of incomes, limited access to services, and cannot afford. If they have to go to the private pharmacy, they could not afford the private because loss of job of the household breadwinner. So, and disruption of the supply chain. These are some of the challenges that we faced during the pandemic area, which made it difficult to render the family planning services during the pandemic times. So these are the guidelines provided by provision of reproductive, maternal, newborn, child, adolescent health plus nutrition services by the Government of India. So these were the limited services that were allowed during the pandemic timings, and they are classified these services, what kind of services can be given to what kind of zones. So depending, this is a containment zone where the concentration of the cases are there. Beyond that, there is a periphery of this zone and there is a buffer zone. So depending on the what zone the patient is coming from, the family planning services could be offered comfortably. So according to guidelines, the containment of the buffer zones, sterilization process allowed only on demand to all walk-in client in the healthcare facilities which are already admitted. The patients who are delivered already in the hospital or had abortion, they could be given sterilization facilities. Fixed day sterilization, however, was to be limited, and these patients needed COVID testing to be negative before they can go for sterilization. Postpartum and post-abortion services also were allowed beneficiaries already in the health facilities, but if the patient is coming from the home with the view to get a sterilization done, it could be deferred to the comfortable time when the patient has overcome her symptoms of COVID-19 or the isolation period is over. IUCD, like the long-acting IUCDs, like the injectable metronidazole acetate was allowed for walk-in clients. There was no reservations on those contraceptive measures. PP IUCD and post-abortal IUCD are definitely concurrent with the delivery guidelines. They were preferred because these are the measures by which a patient who delivers in the hospital care facility goes home with a IUCD and a contraceptive plan. So she does not have to come to the hospital again. One of the visit can be saved, and so these were preferred. So these are the services. COVID suspected provided by the COVID testing is not mandatory, but ICMR testing guidelines should be followed. Definitely in these patients who are seeking family planning services or they are seeking contraceptive facilities, the ICMR testing suggests if the patient is coming from the containment zone or hotspot area, or she is coming from a travel abroad, then only, or she's symptomatic, then only testing should be done. Home deliveries of the telecommunication services and telemedication services were are advocated, and the home delivery essential supplies like the medications and the could be done. That is one way to get out of patients coming to the hospitals. So contraception was of course advocated by this forum, and the government of India says we prefer long acting contraceptive devices like the 5-year ICD or 10 years copper T380A, because once it is put, it is effective for 5 to 10 years. So patient does not have to come to the hospital. If the patient comes to the hospital, IUCD can be inserted. Postpartum and post-abortion IUCD was preferred, and there was no need of a routine COVID testing. And the last but not the least, the abortion services were affected in the COVID pandemic time. During Government of India declared safe abortion as an essential healthcare service on April 14th, the country was still under the COVID-19 lockdown, because they said there was an increased demand for abortions during that pandemic time, during the lockdown, because of confined and the patients were confined. There was increase in the unintended pregnancies and unwanted pregnancies. There was a diminishing supply of the contraceptives, or because of the lockdown, women could not go out. They were just allowed to go for essential services, and they could not go out to buy contraceptives from the pharmacies. So that led to an increased domestic violence, also contributed to the unwanted pregnancies. So many of these women needed abortion, safe medical abortion services, but they could not come to the hospitals for variety of reasons, because of non-available transport or lockdowns and isolations. So many countries, including India, have approved teleconsultation for medical abortions and telemedication for the first trimester medical abortions, and patients could consult physicians on the phone or on the net and the social media, and they could avail the medical abortion services. And this was in alignment with the WHO guidance, which confirms that the self-managed abortion is safe in pregnancy. Individuals have information, if the individuals are given information, what kind of precaution to take, what kind of medications to take, and what is the protocol of taking these medical abortion pills, and how and when they should report the hospital if at all healthcare is required. So this was approved by during the lockdowns, when the women could not come to the hospital but they were in need of an abortion. So they are not to be denied the safe abortion practices, and could be given medical abortion based on the teleconsultation and telemedication facilities. So thank you all. This was all for the talk. So I bring it to Dr. Ohri now. This was the last topic for the day.
Challenges in the COVID scenario, and how we responded as a world to all those challenges, and how the government of India and the people at large and the society, civil societies, and the medical fraternity has kept going in those tough times. So that's another story we could understand, besides what the slides and what the ma'am was telling. So this is again something learning lessons for us. And thank you, ma'am. It was wonderful.
Thank you, sir. Thank you,
sir. And now we close up the session for today, and we'll be meeting you tomorrow again, same time, and we'll continue with the further sessions for day 3. So thank you, everyone, being with us. Thank you.